Good morning, everyone. So thankfully we have our names and we can put them on here and it makes it easier to learn everybody's names. Thank you for having me. Oh, hold on, I've got this agreement to share to allow recording in the middle of the screen. But so I am Patti Juliana. I am a social worker by training and an administrator by default because I learned that's the only way to get things done at times. It's also the only way to corral some funds to do what you want to do. I started out in child welfare. That had me working in that led me to work in substance abuse because of all the kids that were being removed from the home because of addiction and sometimes returned home before the families were ready, the parents were ready. So took a 1-year demonstration grant to the Albert Einstein College of Medicine. Honestly, my job was do something, figure out what do the kids need, figure out what the parents needs, and then do it. And then I thought I'd be there for the year and that would be it. But I remained for the next 20 years and didn't leave the field. It's been an extraordinary experience. I've gotten to do many different things with many delightful professionals, pioneers, and everything. So this is my first ECHO. I've heard about this for a long time. I held one of the addiction technology transfer centers for, then it was just New York, and then it just, I haven't been actually in it. So glad to be here. After I was at Einstein for 20 years, I moved to Beth Israel in Manhattan for 10. Started out with just opioid treatment, and then while I was there, they would say do something on the inpatient side. So I ended up with a full continuum. Then after traveling 3 to 4 hours a day for 10 years, I said, okay, I'm going to be healthy, and took a position locally. I'm on the border of New York and Connecticut. So took something in Connecticut. I know what it is to work in 2 states. So the dual licensing part is a challenge. In any case, then I received a call from CSAT asking if I would consider working there. Got to do some wonderful things with wonderful people, and I'm happy to have the opportunity to share the final rule for Part 8, which has taken the last 2.5 years to move to full regulation. And so finally it was approved in the end of January. It was announced February 2nd. So yes, this is hot off the press. Oops, I'm not even sharing slides. 1 second. My system was a little finicky about sharing. So I am using 2 screens. I need to look at one in order to talk to. You are all here. You all have a bit of a background in addiction treatment. I'll go a little bit quickly through some of these. Some you might have seen before, and this one you didn't see before. Some you might have seen before, and some might be familiar to you because of the data. Primarily, I'll go through the changes in training expectations and a bit of Part 8, and then introduce some of the training and technical assistance work. So even though my primary career has been administrative and both administrative and clinical, I've done a lot of teaching in schools of social work and at the medical school at Einstein. And so I am very much a workforce development person, which is why there are objectives. All right, so we're here to talk about opioids. No, not kegs. But we have the essence of this slide and the next is that there are simply too many overdoses. We did add on at SAMHSA an alcohol. We have we have the physician clinical support system. It's actually now practitioner clinical support system, but that is a training and mentoring system. We added one for alcohol because of the amount of alcohol deaths as well, but this is to focus on opioids. So too many opioid deaths. Fentanyl is a lot of what is driving those deaths. With These are, these also show the amount of deaths related to cocaine, heroin, methadone, and natural and synthetic opioids. So it captures the trait. Still, it is the lead. I do want to note one thing though. This is this bottom purple line that is flat. Um, this has been the same for a very long time and did not increase. Just want you to bear this line in mind when we get to the part 8 conversation. It's low, it's short, and it's flat. Um, Despite all of the efforts and all of these deaths, we're still not reaching people who most need substance use treatment. Um, Many of them in their adolescence and young adulthood. That for me is the most worrisome group. It's most complicated too. Takes a interdisciplinary team and a lot of strong family practitioners to be able to identify and mobilize the families. Part of the reason we're not meeting, we're not able to reach so many is because people are living with uncoordinated systems. There isn't enough of this. There isn't enough of integration and pulling it together. Housing is treated as a separate entity in many cases. Um, People might enter different systems at different points. It's all people with substance use disorder. We need the kind of collaboration that this ECHO builds, which is interdisciplinary and local. Well, more local than a national approach, even though you're covering the whole state. So we need to be able to capture people wherever they are in their progression. SAMHSA is doing a lot to address the issues. These are SAMHSA's overarching priorities and principles, very committed to trauma-informed care, equity, data and evidence, and recovery. I've been able to access resources through SAMHSA for the last 40 years of my career, and I will say that the amount that is going on now, I haven't seen in those 40 years. And I'm not the only one doing. So it's not about me. Um, the focus, we have 5 focus areas, as you can see here. Preventing overdose, of course, comes with treatment, but there's also efforts to distribute naloxone and to address multiple needs. Very actively focused on integrating behavioral and physical health. I had a precursor experience for that when I started at Beth Israel. The president of the hospital called me in. I was only there a month. I couldn't imagine what I did, but he said he wanted me to make substance abuse treatment mainstream in an 800-bed hospital. Thankfully, I had that experience because now I can translate some of it. Promoting resilience for children, youth, and families, strengthening the behavioral workforce, and enhancing access to suicide prevention and crisis care. We have the whole 988 effort, which has just been remarkable to witness. Our main focus, or especially my main focus, is on overdose prevention. We have the overdose prevention strategies. This is the White House National Drug Control strategy out of the Office of National Drug Control. At least 6 of the strategies there fall into the division that I manage, which is Division of Pharmacologic Therapies. We are working to integrate medication-assisted treatment or medications for opioid use disorder into jails, prisons across the nation. And excuse me, we also we've managed to help the Bureau of Prisons set up the federal system, set up opioid treatment services in all 96 of their sites. We're doing a lot of workforce development efforts, which I'll go through. So we've been promoting this 4-pronged approach, weaving in harm reduction and recovery support into everything. So there's primary prevention, but treatment is prevention as well. One of the ways we're trying to do this is to get out of the traditional way of doing treatment, which is methadone could only be provided through opioid treatment. Buprenorphine did come up, and we're trying to encourage the opioid treatment programs to to partner with the correctional settings in harm reduction programs, setting up primary care in a harm reduction, in a needle exchange, and a syringe exchange program has been very effective. Across specialty addiction treatment and infusing use of medication in residential rehab programs. And then across healthcare, we have a number of different emergency room based services. One is it's called ED ALT. It was written into congressional acts that it was a demonstration grant originally to provide alternatives to opioid treatment, but it's also doing a lot of education of practitioners in the emergency rooms. And many of those they've been building bridges from the emergency room to treatment. And given what I do, which is what our group does, which is half of which is certification and accreditation of opioid treatment programs, we're really trying to educate them to be the partnering. I guess we all take a field of dreams approach, which is you build it, they'll come, but that doesn't happen. So we're doing a lot of work to expand access to treatment, partly through educating practitioners of all kinds, promoting interdisciplinary work. Part of that White House agenda was what'll be launched today, I think, was building some curriculum for use in colleges and universities, in undergraduate, graduate healthcare programs, so that people get substance use training in during their academic experience as early as possible in their career. Within the division that I have, we have what's called the provider support branch. So it supports the practitioner clinical support system, and which is one cooperative agreement for alcohol, one cooperative agreement regarding opioid use, and then a number of universities. While I'm at it, there is a notice of funding opportunity available now. It's due April 15th, and it is focused on curriculum development in regular academic programs, graduate healthcare programs. And it provides some hands-on training for the students and a couple of other things. So I'll come back to that. The provider support group focuses on messaging to practitioners, working with our federal partners, DEA, FDA, CDC, NIDA, NIH, which is where a lot of my time goes. Training and technical assistance, I mentioned the clinical support system, and technical assistance provided through a number of different platforms. The rate at which publications are coming out of SAMHSA is a little mind-boggling. Very focused on evidence-based practices. Significant outreach to support practitioners. Once people have the training, they are often uncomfortable actually prescribing. They don't necessarily know how to connect with community resources, so we're providing that information. There was a summit about pharmacy access. There were many places in the country where a provider would write a prescription, but then the patient would take it to a pharmacy and they couldn't get access. There was one summit. There was a second one recently, and then we're doing a lot of work with the pharmacy associations as well, and with the DEA, because of the concerns that are out there from the wholesale providers, the distributors, and the pharmacies about becoming a focus because of the amount of buprenorphine that they're dispensing. So in terms of expanding access to the medications, we know it works. You know it works. Some of you have been doing this and can speak to this too. It just reduces overdose deaths, getting people treatment as soon as they can is part of the reason we have been integrating a harm reduction as much as possible. You'll see shortly a couple of different ways we're doing it. The research is there, the evidence is there. There are some barriers. There were barriers with Part 8. I will be the first to say it. But there also were other barriers. Stigma is the biggest barrier, both for the patients and for and for the providers, and for people who are not necessarily coming forward. Any which way we can address stigma will be most helpful. The strict monitoring is related to Part 8. Geographic and transportation challenges. One of the first national level things I had to handle left me a little bit bewildered. It was a call from an OTP in the Rocky Mountains, and they had a snowstorm coming. Well, they didn't, I had to understand what that meant for them. And no passage. They didn't expect to be able to get through for a month at least with the snow that was coming. And lack of providers. We had, before the waiver for buprenorphine was removed, if you are familiar with it already, we had about 130 people who had waivers to prescribe buprenorphine. With it being removed, there's 1.8 million prescribers who, with a DEA registration, with an appropriate DEA registration, who can prescribe now. So there was this waiver. It was signed into law in October of 2020. It was as if we had to introduce buprenorphine to the world. I did have the opportunity to watch this happen. Patient cap was first, it was about the patient cap. Okay, 30, we could do a little bit more than 30 maybe. CARA was implemented, the act to expand that included expanding the cap. We wrote some practice guidelines for these that then needed to be revised. And then we had the waiver system. The Support Act then expanded it to nurses, nurse practitioners, and PAs. And then if you look at this timeline, in October of 2018, it was expanded to nurses and PAs. And then I guess they learned that it could be done safely. And then it was removed in December of 22. We had actually December 29th. We learned on the 22nd of December, and I had a whole staff that had been working solely on the waiver. I waited until after the holidays to tell them that it was removed, and their jobs just changed. With the Consolidated Appropriation Act in 2023, there were two significant parts to that to facilitate expansion. One is removing the waiver. As I said, it went from 130,000 prescribers, potential prescribers, to 1.8 million who could potentially prescribe. And it also set up this requirement for 8 hours of training, which those of you who are practitioners have probably received a lot of notice about. We've had to do a lot of work with the Department of Justice and the DEA about implementation. The act also pushed some of the oversight. I want to call it oversight. That it wasn't really oversight. It was just approval of or verification of training and qualification to prescribe when we had the waiver. It moved it from SAMHSA to the DEA, but the DEA doesn't consider themselves a clinical entity, so we've done a lot of work with them around this. Right now, there is no need for, you will see if you go to our website, it still has this up. We don't accept notices of interest, otherwise known as waiver applications. Anyone with a DEA registration that includes Schedule III authority can prescribe buprenorphine. If depending on the state, some states have more restrictive rules for nurse practitioners and PAs. Some require supervision. 1 second. The MAID Act, in response to the MAID Act and the need to provide training or the need for practitioners to verify that they had training, there were a couple of different ways that they could qualify. If they already had a waiver, it was accepted as completing the 8 hours of training. If they attended a university that had fully incorporated SUD curriculum and they graduated in the last 5 years, then they qualified, their training could count. But there were many there were many unanswered questions in that surprise act.
Patty, we have there's a question in the chat.
Okay.
To circle back, you said 1.8 million eligible prescribers of MATs currently. Do you have any estimate on how many of those 1.8 million are actually prescribing?
It's not many more. Okay, but this act just happened. It happened in December of 22. It was not that long. Now, we do know from a study that we did, there were 2 studies. One I don't think is published yet. The other one is published. We did, it was NIDA, SAMHSA, the CDC participated in evaluating the effect of removing, there was that, with removing the training requirement for people prescribing up to 30. A lot of practitioners, a lot of emergency room practitioners pursue that exempt status. The numbers didn't increase that much. The numbers of actual prescriptions written did not increase that much. The follow-up study now, in the last maybe 3 months it was completed, it showed the uptake isn't there yet. I don't know if it's the uptake of prescribers or if it's the uptake of people in need of treatment, but it hasn't increased that much based on the data from the insurance companies, especially Medicaid and Medicare, and also the privates, but also in terms of some of the visit information that we were able to, I don't have access to that to that data, but based on prescribing practices, there hasn't been that much of an increase. We're hoping to see it come, and that's one of the reasons why I'm doing this, because that's in our wheelhouse. So yes, was there anything else? I see 22 chats, but I can't. Shall we come back to questions? Or are you going to monitor them?
Well, if some come up, and I know Dr. Marsh said if we don't do it in residency, the training, we're unlikely to add a skill. Residents are getting more exposure. This data about new grads prescribing would be really useful.
I'm sorry, could you say that again?
It was just a comment from Dr. Marsh that says if we don't do it, the training in residency, we're unlikely to add a skill. So that's kind of the sweet spot for introducing new skills. Residents are getting more exposure, and this data about new grads prescribing would be useful.
Okay, I'll note that.
I am that, Dr. Marsh, but I think if you go ahead and then look at the chats later, often they sort of group up into a thematic grouping, and then it's easier to address them at the end when you can focus on them.
Get topics. Okay, that's fine.
And we do
have time. It says 7:34. Sorry.
Yeah, we do have another comment by Lane Gritty that, and I don't know, Lane, if you want to share that, but in her work at a Summit County, in a jail in South Carolina, it's frustrating because they don't treat addictions. No buprenorphine, not even NRTs, only naltrexone. And what we've discovered, at least in Ohio, that funding is a key issue, and that each county jail is its own fiefdom. And what services are provided there seem to be dictated by a sheriff's department rather than the medical community. And until insurance is able to reimburse for people incarcerated, funding is going to continue to be an issue there with medications.
I'll come back to that. I'll come back to that at the end. We're doing a lot of work in jails and prisons, and can fill you in. And for general knowledge, though, in January of, I'm sorry, a year straight, January of 21, the federal government, federal judges determined that it was an ADA requirement that jails and prisons provide medication for people with opioid use disorder. It's a very practical thing. I'll tell you in a bit about what we're doing in terms of that. Medicaid has set up a waiver. The states can request a waiver so that Medicaid can cover treatment in some ways. Some states have done creative funding, but I can tell you that when they realize that that methadone only costs about $30 a month, where Sublocade costs more like $1,200 to $1,500 a month. And then if the person is released from the jail, then they're stuck with a prescription. It makes the budget equation a little bit simpler. I just came off of 2 days with 8 states. Ohio was present. There were some jails in Ohio that were involved in a Building Bridges effort, which is to infuse medication in their jails. I don't remember the county name, but as I do, I will share it. Okay, recommended elements. We posted with the MAID Act. People were calling and asking, what kind of training should I have? The DEA asked us to put some things together. So we compiled some preliminary content that was recommended. I will say we are not the Department of Education, but we have a number of us who have taught. So we compiled the key areas. This is available on the website, which I'll show you in a minute. And some schools have actually been using this for content for their programs. So now we come to part 8, the other area that was a big barrier, besides people being comfortable prescribing and talking about opioid use in their regular practices or in their regular mainstream healthcare settings. The rules for opioid treatment were really very restrictive and a problem, especially with people who were working full-time or even part-time for that matter, had families, students. It used to be required that they came to treatment 6 days a week or 7 days a week, depending on the state. And that's near impossible for anybody. I can't. I mean, I'm happy I can get to go for a walk for 6 days a week, but to get to a treatment program every day and wait online to get your medication was a significant challenge. The reason they were restricted is that those original rules that were from 2001 came out of experimental design. This is still a relatively new field. It's only 50 years old. So the reasons why we were pushed and needed to do it, the pandemic required us to change how we were doing treatment altogether. So we didn't want people coming into the clinic. We didn't want them sitting in waiting rooms. So we needed them out. Remember that purple line that it was flat? People started getting, because of COVID-19, they started getting more take homes, up to 30 bottles at a time, 28 bottles. The rate of overdose deaths from methadone did not go up. It was unchanged. The rate of diversion was unchanged. And so it became an in vivo experiment that we were then able to use to help loosen the regulations. The overdose crisis also called for us to be more patient-centered, revise those into a more patient-centered way that allows access to care. And then we had feedback from many stakeholder groups about the flexibilities. They worked, so why don't we do it? It was not based on any experiment other than, I mean, it was based on a ton of literature and research, but not based on the amount of feedback we got about it was significant. This is just an add-on. We had to change it because there were so many outdated aspects of it. LAM was included, that was black box warning, and hasn't been used since 2002. And there were a lot of references to paper. So those are gone. The data also supports the changes that we made as safe. So there's JAMA, I think methadone is the most researched medication for treatment that we could than any other. There were underlying values and principles. It has been an incredible experience, professional experience, to work together with some of my colleagues on doing these revisions. Thankfully, we are all in the same place in terms of promoting patient-centered care, shared practitioner and patient decision-making. This is a tradition of telling people what they need and how they should live their lives, but being flexible, responsive, and use of evidence-based practice and removing stigmatizing language. It was very fun to be able to cross out a lot of content. We were driving for building a more patient-centered environment, fostering trust. That's what we heard from the patients across the nation. Thank you for doing these flexibilities. I felt like my program trusted me. I felt respected as a person. We heard it loud and clear. Acknowledging the skill and patient-centered understanding, increasing the skills of the practitioners, letting practitioners use judgment. There were 8 points of criteria that were written to the prior version that were used to determine if somebody could have take-homes. It used to take 2 years to get take-homes, but they were so prescribed, there was no such thing as use of judgment. If somebody wanted to use good judgment, they had to write an exception and submit a request to SAMHSA that then got reviewed. There's a lot, you will hear a lot about clinical judgment. Creating responsive, flexible OTP services that are grounded in evidence. This refers to the use of mobile units and medication units. There were also a couple of other things that were written in to foster collaboration with other entities. And then addressing the stigma and promoting medication as treatment of a chronic disease. We reference diabetes a lot. It's a similar model. So I talked about I'm going faster because we won't have time for questions. Making the flexibilities permanent. That's about medication specific and the take homes. Expanding access to care. We had a dilemma with those under 18 because the way the regulations were written said they needed 2 documented unsuccessful attempts at withdrawal, but then they would go to the hospital for a formal scheduled tapering or management, but the insurance companies would deny it. So it just didn't make any sense, especially in this era of fentanyl. And the 1-year requirement for opioid use, that there had to be this is a leftover from the world of experimental design. That 1-year requirement, I'm sure will end up eliminating it will save lives. Split dosing is a decision on how you prescribe, on how somebody receives their medication. I had a lot of services for pregnant women, and it's a little hard to take something that can leave you feeling nauseous if you are already feeling nauseous. So we built it in and made it standard, that it didn't have to be by request. The incorporation of telehealth and integration of care, of use of telehealth in OTPs will address a lot of workforce shortage issues, potential for medical screening. We clarified the medical screening for medication versus a full assessment that has to be done within 2 weeks now, so that people could get into treatment because of the waiting list, because of the shortages of staff. There were too many people who had to wait a month to get into treatment. I talked about incorporating harm reduction and okay. Other ways that the final rule expands access is including NPs and PAs as fully qualified practitioners who can assess for OUD, and in an OTP, it's writing an order. It's not dispense. They can dispense, but they write an order. It's not prescribing. Expanded the access, a range of services that are allowed in medication units. We have an interim treatment written in that is a short-term means of addressing waiting lists when there are waves. we're hopeful that this last bullet will help expand access to medication in jails. Some jails, some prisons have designation as hold DEA registrations as a hospital or clinic. And right now they can dispense methadone if the OUD is secondary to a primary health condition. We're working with the DEA on that too. Okay, now it'll go faster. These are just some examples of some of the resources that have been developed in the last couple of years. There's just tons of material there. The way you find them is you go to SAMHSA.gov. Here's the SAMHSA.gov over here. And you can look it up by publication or by program. And then under practitioner training, there is a lot. These are resources that you can draw upon individually or for the training entity that you're working with. The ECHO can use these. The training and technical assistance programs are not housed, they're not in the same spot. You have to go to practitioner training and then you can find all of the TAs. This is not all of them. This is only 6 of them. There are, I don't know how many, there are at least 40. Here's our practitioner providers clinical support service for OUD. We have the Rural Opioid Technical Assistance Center. There's at least 40 others. There are many kinds. There are tons of resources out there for you to draw upon for your individual organizations. There are the technology transfer centers, centers of excellence. We have one thing that comes up in substance abuse a lot is 42 CFR Part 2 about the privacy laws for addiction. Part 2 was recently revised. There is a Center for Excellence on the privacy laws. And there are technical assistance programs. There are also regionally focused programs. The ATTCs are more regional. I forgot who's the keeper of the keys for Ohio. The ATTCs are more addiction specific. There's the MHTTCs as well for mental health. There's a prevention TTC. The ORN comes out of the state opioid response grants. This is held by AAP. I'm sorry, it's held by AA, American Association of Addiction Psychiatry. And they have done a tremendous job of building a network. These are some of the other ones. We have the alcohol, PCSS as well, I mentioned. Come on, there we go. So we have done a lot of work in terms of policies and expanding access to patients. We are doing an awful lot in these areas, and we are looking forward to seeing the development of partnership and collaboration for the purpose of expanding access to care. And on that note, I will stop share and gives us a few minutes for questions still. I'm sorry, wait, just give me a second for my chat to pop back up, unless John, you've been.
No, and we